All right, everyone, we're going to get started. Welcome, everyone, to this RFS webinar. My name is Dan Sheilo, and I'm the chair of the Membership Council of the SIR Resident Fellows and Student Section, or RFS. For those of you who are joining us for the first time, the RFS hosts about 2 webinars per month, and we actually record many of them and post them to our YouTube channel, which is called IR Education, so please do check it out. We have some great talks up there. Please also check out the website, rfs.sirweb.org. It's a great resource for trainees. We have an FAQ on the new IR residency, information for people applying to IR fellowship, and clinical materials like Case of the Month. Having said that, tonight I'm excited to present the second talk in our series on acute stroke therapy. The title of our talk tonight is Changing Acute Stroke Treatment, A Journey. And our speaker is Dr. Mayank Goyal. Dr. Goyal is professor at the University of Calgary, where he also serves as director of research. Dr. Goyal was an author on papers such as the ESCAPE and REVASCAT trials, which helped to prove the safety and efficacy of intra-arterial stroke therapies. And I'm thrilled that he's agreed to speak on this topic tonight. So without further ado, I'll hand the floor over to you, Dr. Goyal.
So thanks, Dan. It's a pleasure to be here, and thanks everyone who's attending. And I think Dan mentioned it earlier, but don't hesitate to ask questions in between. I'm going to cover quite a bit, and depending on what your background is in terms of which field of medicine you're coming in from. So a lot of this talk assumes a significant amount of knowledge of neuroanatomy and imaging and stuff. But anyway, let's go through it. And I don't exactly know where different members of the audience are coming in from. So hopefully it'll still be sort of clear. The reason you see these flags on the side was that when we made the ESCAPE trial, these were all the countries that were involved in the ESCAPE trial. So that's why we sort of put these flags there just as a marker of that this was a multi-centric across the world kind of trial. My biggest disclosure is that I'm presenting this talk here, but it's all about teamwork. So I'm sort of sitting here giving you this talk, but essentially it's about a whole bunch of people putting their efforts together to change the practice of medicine. This is sort of my formal list of disclosures. I was the PI of 2 big trials. I was the core lab for REVASCAT. I do consulting for some companies and some IP, which I'm going to talk about. 2013 was these 3 NEJM papers which were negative, and that was kind of a depressing day for the field of acute stroke. And from there on, we started sort of trying to understand why were they negative, what needs to change, and things like that. And from there on, I'll show you sort of how things proceeded. This was the main result of IMS-III, so we were involved in IMS-III. I was one of the authors in IMS-III paper. Here, Calgary was significantly involved in it. This is the main result of the paper. And just to clarify, for someone who doesn't know, you'll see a lot of slides that look like this. So this is the MRS scoring system. 6 is dead, 5 is, people say, worse than dead, 0 is normal. Generally speaking, 0 to 2 is considered good outcome, 3, 4, 5 are considered sort of bad outcome, 6 is dead. You'll see a lot of slides that look like this. But this is the bottom line slide, bottom line results of the IMS-III trial, which showed no benefit for endovascular treatment. This is a slide I made in 1999 when I was a fellow. So here's sort of the, so to speak, the summary slide, which would theoretically be the last slide, but I'm showing it to you first. That essentially, here's what we know. The dead brain is dead brain. It's not like liver, it's not like kidney, it's not like other parts of the body. Dead brain is dead brain. Once brain dies, there's nothing you can do about it. Early in stroke, time is brain, so the faster you can open the vessel, the better it'll be. And then opening vessels helps. So this is sort of the broad picture summary conclusion. And this was written by Jeff Saver, a colleague of mine in UCLA. 2 million neurons per minute are being lost during an acute stroke or a big acute stroke. And it's a good way to think about the problem that, let's say you waste 5 minutes in a particular thing, 10 million neurons are gone. And those 10 million neurons could be critical in recovery for a particular aspect of the person's life. So time is really critical. And once again, this is unlike any other part of the body. In terms of trials, you guys are very familiar with it. This is sort of the levels of evidence. And what I'm going to show you is in this top part of the pyramid, most of the stuff that we do lies in this part: case series, case reports, expert opinion sort of thing. But here's the part that we'll be living in today. We also did some data on time is brain. So this was published in Lancet Neurology. Quite a few of us from Calgary were involved. So on the x-axis is time from stroke onset to reperfusion. The y-axis is likelihood of a good outcome. And as you can see, as you go later and later and later, the likelihood of a good outcome keeps getting lower. So I started working on this a while ago, 3-4 years ago, when we said, okay, well, basically the rest of the world is moving too slow. We need to move faster. So we said, okay, we're going to try to open vessels within 1 hour of CT head. And the median of the world at that time was 3 hours. We said we're going to try to open it in 1 hour. And this was the first paper that we wrote of opening vessels within 1 hour from CT head. And we had a lot of struggle getting it published because people didn't believe us that this can be done even. So this sort of giving you a little bit of a historical perspective. Now, we also need to recognize what we don't know. So we don't know is in one individual patient, what is the rate of infarct progression? What is the rate of penumbra change into core? What are other variables? How do they influence change in blood pressure, change in collaterals? Are all patients built equally, or do diabetics behave differently? Hypertensives behave differently? Is an 80-year-old different from a 50-year-old? How does brain eloquence come into play? What part of the brain is more important than another part of the brain? Those are the kind of things that we don't know. So I came up with this idea. This is again an old slide from like many years ago, but I just keep it there. So essentially, since dead brain is dead brain, you don't want to take patients with a large amount of dead brain. So you have to take patients that have a relatively small amount of core, and then you have to take patients that are worth fighting for. So, not everyone is built equal. You have to sort of understand the patient, understand the neurological side of things, understand their family life, understand their quality of life. And then you have to take patients in which a natural history is likely to be bad. So you don't want to take patients who have a very minor deficit and start doing sort of crazy kind of procedures. But once you've sorted all that out, you basically work like crazy to open the vessel, because that's the only thing that will stop your brain cells from dying. And don't waste too much time on extensive imaging and post-processing. And there are many components to a success. You can't do this alone. It's teamwork, organization, setting up the correct process. And imagine this is what the patient has to go through. Someone recognizes stroke, calls 911, the ambulance arrives, loading into the ambulance, taking to the hospital, the correct hospital. And this is critical. And I travel a lot around the world. So for example, this is a much bigger problem in US compared to Canada, where the patient ends up going to the wrong hospital first and going to the right hospital second. In Canada, we've been able to set up systems of care where we can centralize it and train the ambulance drivers to come straight to us. Anyway, once the patient gets to the correct hospital, evaluation by the ER doctor, then the imaging gets done, evaluation of imaging, the team has to formulate a plan of action, obtaining consent, organizing the angio team, preparing the patient, see if anesthesia is required, puncture the groin, access to the relevant vessel, then you've got to go into the brain, then finally achieve recanalization. And all along the way in this whole process, 2 million neurons per minute are dying. When you go to meetings, what happens is people have a tendency to talk to this bottom part, which is, so to speak, the interventional part, but they don't focus on the rest of it. And from an overall big picture, even if you speed up 5 to 7 minutes here, that's great. But if you sort of waste 2 hours here going to the wrong hospital, then you haven't really won the battle. So here's a way to think about it. 911 to ER of the correct hospital, ER to CT, imaging to groin to recanalization, and all parts of the process have to work well for there to be an overall success. So we wrote this editorial, again, made quite a while ago, 2011, that we need to have a systems approach rather than sort of an individual thing, my device is better than your device kind of approach. So we started working on this again a long time ago, where we said we need to organize pre-notification. And one of the things we were able to organize here in Calgary is that if the paramedics pick up a big stroke, they're able to tell us something like last seen normal at 6:40 p.m., expected time of arrival 20 minutes sort of thing. So then we can organize ourselves, and we've been teaching paramedics how to sort of identify a big stroke. The second thing we started training people is that, the typical scoring system is an IHS-SS, which I'm sure you're aware. But when we traveled around, one of the things we observed was that 10 minutes were being spent in just doing the NIHS score, and resident would be telling the staff it's this, and then they would say, well, I'm not sure it's 16, I think it's 18. Well, we said, does it really matter? And we started training people. The idea of saying something like NIHS is 16-ish, as opposed to saying it's precisely 16. And then we started to work on parallel processing where, one person is taking the history, the nurse is setting up a large bore IV access, someone is looking at the vitals, someone is drawing up the blood, and then we have simultaneously moving the patient over for imaging. I'll digress for a little bit, talk about imaging, and then we'll come back to the mainstream. So anything in life, you have three choices. You have three choices right now in terms of you can listen to this talk, you can not listen to this talk, or you can listen to it later on in a sort of a YouTube recording. Or you can say, well, let me decide later on sort of thing. But depending on whether this talk is being recorded or not, essentially, if you say, well, let me wait and go eat dinner and come back and listen to this talk, then the talk opportunity is gone. So essentially, in anything in life, when you have three choices, when you wait for more information, it may be the same as a no decision. So you go eat dinner, by that time the talk is over, and if it's not being recorded, then you sort of are not part of it, sort of thing. And depending on the rate of change of information, the way that it plays out is the longer you take to make a decision, the less likely your decision has any meaningful impact. So in the world of acute stroke, if you don't make a decision quickly, then the decision is the same as a no decision. So we have to select patients appropriately for endovascular treatment, and these are the choices that we have. CT plus CT angiogram, CT plus CT angiogram plus CT perfusion, or we can do MRI. And essentially, it's a question of the balance between time spent, local infrastructure, comfort level with decision making. All those things have to come into play. I wrote this editorial probably 2-3 years ago. I call it the denominator fallacy. And this applies to every aspect of medicine, but I just used stroke to illustrate it. Imagine two cities, Metropolis and Gotham City, and imagine they have similar population and demographics. And imagine that 200 people have an M1 occlusion in both the cities. Now, Batman is a simple kind of guy. He does a CT angiogram, takes 120 out of those 200 to endovascular, and 60 of them have good outcome. So the way that we traditionally report our outcomes is it'll be 60 divided by 120, the people we took for the procedure, and 50% have a good outcome. As opposed to Superman, he does complex imaging, MR, perfusion, this, that, and the other, spends 60 minutes imaging, finally takes 20 patients for endovascular, and 18 have good outcomes. So he's got 90% good outcomes. So they meet each other, and Superman tells Batman, oh, my outcomes are way better than yours. So my patient selection is better, my interventionists are better, my devices are better, and this is why I'm better than you. And this is what I see happening all around. While the real truth is that in Gotham City, 60 out of 200, the total number of people who had strokes, 30% had good outcome, as opposed to 18 out of 200, 9% had a good outcome. So essentially, the only denominator that makes sense is the total magnitude of disease in the population, not the total number of people who showed up at your hospital, and definitely not the number of people that you took to the. And that is something which is important to remember if you have to make an impact on the disease itself. You can take it into a current perspective as well. Like right now, there's a major migrant crisis in Europe. So you can talk about, well, if you let 5,000 people ill, and those 5,000, what are we going to do about them, and how many of them are well settled at the end of 1 year? Or you can think about all the people that did not make it to your country or whatever, and what's happening to the million people who are out there, kind of thing, and which is a better this thing of overall success of the process. Perfusion imaging has lots of problems at the current moment, in our opinion. We really don't use it. We think it doesn't change decision making. In fact, I'm going to show you some data that it makes decision making worse. We wrote this editorial saying perfusion imaging, let us improve the science before changing clinical practice. And there are many, many data sets which show that perfusion imaging takes a significant amount of time. This is from 5 big American centers. And essentially what it showed was that on average, there was over 60 minutes additional taken in doing perfusion imaging. So there's something to keep in mind. I wrote this paper in Circulation. This was from the IMS-III data. And two interesting things in this IMS-III data was that if you look at the time for CT angiogram, we can consistently do CT angiogram in a very short period of time, 3 to 6 minutes. The other thing is because CT angiogram helps us choose the patients, understand the anatomy, the overall workflow becomes better, and we open the vessels faster if you have the CT angiogram information as opposed to if you don't have the CT angiogram information. So essentially, this is the Calgary way of thinking about the whole imaging philosophy, the 3 C's. Clot, it has to be a proximal vessel occlusion. Core, it has to be a small core. And collaterals that will keep the brain alive while you go and open the vessel. We really don't need information about penumbra to take the decision making, it's implied. However, if I could get reliable penumbral information in 2 minutes in 4 million neurons, sure, I'll use it. But if it's going to take me 100 million neurons, then I don't really want it. I run this website, aspectsinstroke.com, gives you a lot of education about the imaging side of things. If you guys are interested, go check out the website. So then we said, okay, collateral imaging in terms of it's a struggle, and how do we sort of understand collaterals better? So I came up with this idea of sort of doing a 3-phase CTA in which you go down, come up a second time, go down, and then you come up a third time. And then we started using this, and we almost created a new language of communication. So this is now how we communicate now in Calgary. 74-year-old, left hemisphere syndrome, 100 minutes from onset. So remember, we don't care whether it's 97 or 103. NIHSS 18-ish. This is the CT head. Look at the CT head. You use the aspect scoring system. There's probably a small stroke here, old one. Probably some subtle changes here. Aspects 9-ish, 10-ish. It doesn't sort of matter whether it's a 9 or a 10. CT angiogram done 2 minutes later. There is an M1 occlusion, and we do it multi-phase. So this is sort of phase 1, phase 2, phase 3. And you can see there is an M1 occlusion, and you can see all the collaterals which are filling in. The contrast is reaching beyond the occlusion. There you can see the contrast staying on, and then it clears out. And this means these collaterals will keep the brain alive while you go open the vessel. This also means that your aspects reading was correct. This also means that you can have an estimate in terms of how much it's clearing out. And at this stage, I don't need any more information from decision making. Big bad stroke, NIH of 18, 100 minutes from onset, otherwise healthy person, CT head is good. So I straight away decide this patient needs to go to the endovascular suite. I start moving in that direction. Now, this was part of a study, so we did the perfusion study. We don't even look at it. We come back and look at it after the procedure. And here, as expected, the patient has sort of close to zero infarct and obviously has ischemic brain. So anyway, within 62 minutes of the CT head, I open the vessel, and the patient basically starts recovering right on the table. And this is the follow-up diffusion imaging showing the patient nearly came back to normal, a few tiny hits. The NIHSS 24 is down to 3. So this is sort of the way that we function, and this is sort of the way that we recommend functioning. Now, as you know, radiation dose is a critical thing, so we are very cognizant of that. One thing to remember is that the 2 additional phases of the multi-phase CTA is less than 1 CT scan of the head, and like 1/7 the dose of a CT perfusion, and you don't need to give any additional contrast. So then we said, okay, well, we're thinking about decision-making using collateral, so why don't we do a study? So we set up this study funded by the Canadian Institutes of Health Research, which is called Prove It, which is essentially whether decision-making on multi-phase CTA is better than decision-making by the old-fashioned way of CT perfusion. So finally, we wrote our first manuscript from this paper. This is published in Radiology, came out 5-6 months ago in January, I think. And essentially what we showed was that decision-making on collateral imaging was better than decision-making on perfusion imaging. And here's an example from that paper. So what happened in this patient was 98 minutes from onset, big bad stroke. I looked at the CT, I looked at the obstruction here, looked at the collaterals. We said, okay, let's go. I went to the cath lab, opened the vessel, the patient improved, the patient nearly came back to normal. We went back and looked at the perfusion imaging. And had we looked at the perfusion imaging by currently used criteria, we would have thought this tissue is already dead. There is no point treating this patient. And I'm now seeing like 20, 30 patients like this where CT perfusion would have actually created confusion and would not have helped the process. Multi-phase CTA is picking up. These are all the places around the world which is where it's being used now. If you guys are interested, let me know, or go to the website aspectsandstroke.com. You can send me an email through there as well. Then I started reading math and I read about Bayes' theorem. So we started thinking about how to use that in the field of decision making. And here's a chart that I came up with in terms of do the minimum amount that you need to make a decision. So you start with clinical factors, age, NISSS, time from onset, etc. And then you do a non-contrast CTA. If there's hemorrhage or a big bad stroke, you stop there. And if there is nothing, you do a CT angiogram. And then if you have decision, you go from there. And what we find is in the last 3-4 years, we've hardly ever had a situation where at this stage we can't make a decision and we need to go to the next stage kind of thing in anterior circulation stroke. So essentially we use the paradigm of time is brain, a Bayesian theorem decision making, and this is published. If you want to read it, you should be able to find it on PubMed. So coming back to the original theme of, so once imaging is done, then you need to think about consent and prepping the room, the patient, anesthesia, getting the team together. And then finally, you have to think in terms of groin access, clot access, choosing the right tools, opening the vessel, and the quality of recanalization. One of the things that I did in the trial was we started doing practice sessions with clinicians as to how to take a consent fast. And ultimately, consent is predictable, and ultimately the questions are predictable. And if you're prepared for it, you can do it faster and save a few minutes. Now, obviously, this is a little bit not so relevant now because now it's standard of care. So the consent is a formality in which basically you say, your mother is having a big bad stroke. The standard treatment for this is to take her to the cath lab and open the vessel. It does carry a tiny amount of risk, 1 to 2% that something bad can happen, but overall it's a pretty effective treatment. Do we have your permission to go forward, sort of thing. So now it's become like a 30-second consent, but earlier it wasn't. And this is sort of grade 8 physics series versus parallel processing kind of thing. So then we started teaching people in terms of the idea of parallel processing. You break it up into teams, and different teams have to do what they need to do, and they all work independent of each other, and they finally unite back together at the cath lab and say, okay, let's go open this vessel kind of thing. We started teaching people to take shortcuts when you can. Don't put Foley's catheter if you don't need to. Don't do a groin shave. You can always treat an infection in the groin. All those kind of little shortcuts to save 2 minutes, 3 minutes here and there. So this is sort of how we function now after the trials. NIHSS of 18, otherwise healthy, 65 minutes from onset. This is at 12:20 during the day. All of us converge in the CT scan because we've been pre-notified. Right, in the CT scan, we say, okay, well, this is a person who's eligible for TPA. So the stroke doctor turns around, tells the nurse to get the TPA ready. In the meantime, we get ready for a CT angiogram. We've already looked at the aspects in the meantime. It's a goodish aspects. 2 minutes later, the CT angiogram is there. There is an M1 occlusion. There's good collaterals. Together, we make a decision. Patient is going to the cath lab. At that time, the stroke neurologist starts talking to the family and all those kind of things and making sure about comorbidities. I go straight, start thinking about the procedure, and I'm thinking about, okay, carotid bifurcation, access, where is the occlusion? Are there any aneurysms on the way? What does the anatomy look like? Are there some critical vessels like anterior choroidal that I need to be careful about? And from there on, I go straight to the cath lab. Now, incidentally, this person, because it was part of a study, had a CT perfusion. So once again, this was there at 12:23. 12:49 is when the CT perfusion became available, but we never look at it. And 12:41, I've already punctured, gotten into the carotid. 12:41 is the first one. We go ahead and deploy a stent retriever, and you can see antegrade flow. The patient starts improving, and pretty much a few minutes later, the procedure is over. There's excellent forward flow. The patient is nearly back to normal. And we go back and look at the CT perfusion. So once again, had we looked at the CT perfusion, we may have thought there is no point treating this person because this brain is already dead. So once again, a situation in terms of that CT perfusion can do more harm than benefit. So this is the follow-up MR imaging on this patient, diffusion imaging. Patient is pretty much back to normal. The other thing we started working on was this idea of the quality of recanalizations. The traditional classification that is there is called the TICI classification, and it sort of breaks it up into TICI 1, TICI 2A, 2B, and 3. And 2B is greater than 50% of the revascularization of the area that was occluded, and 3 is perfectly normal. And what I realized was that this is not good enough, and 2B to 3 is a large gap. So we came up with this idea of having TICI 2C, and now it's getting more and more established around the world, and pretty much most of the modern publications that you'll see coming out from here on will be talking about 2C as well. So essentially, this is what it comes down to. This is an editorial I wrote in AJNR. Dramatically reducing imaging to recanalization time in acute ischemic stroke. It's about making choices. It's not about perfection. It's not about having perfect information. It's about taking all kinds of shortcuts that may lead to infection, that may lead to sort of some degree of imperfections, but the idea is to get the vessel open. So this is what the workflow was like in IMS-III. It's almost an embarrassment for interventionists that the median time from IV start treatment to end of IA was 200 minutes. And this is what we were able to achieve in Calgary pretty much consistently. And we started to train other people. This was a study that was out of Europe and Canada. And we started to show similar sort of thing, time is brain, but very quick recanalization. This was published in Stroke. It was from the STAR registry. So multiple things came together. There were better devices as well. And then we kept track of our Calgary experience, and we showed that we were basically being able to consistently open vessels in around 100 minutes from CT, even in the middle of the night. We started working on this idea that anesthesia may be actually harmful. We wrote papers on sort of the harmfulness of anesthesia. In fact, one just came out 15 days ago in Stroke from the IMS-III data, once again showing the same thing, that doing the procedure under anesthesia may be worse than doing the procedure without anesthesia. And it's something that one needs to get used to. It's not something that is sort of totally straightforward. I won't go into the details of this, but there are now many, many publications on this. This is a little bit of an older paper. As I said, there's a latest paper that we wrote, which is in Stroke. We started to develop this idea of having a consistent technique and being always ready. So I call this thing the brisk recanalization ischemic stroke kit, where you're always ready to receive a stroke patient and you try to use the same methodology every time so that you don't have to go around looking for stuff and you're all ready to go. So essentially what ended up happening was that we thought we'd solve the issue of imaging, and we sort of got into grant writing, proving it, writing papers, Bayesian methodology. We improved the workflow. We sort of got into parallel processing systems approach. We started doing training in endovascular techniques, innovation, working with industry. And overall, we developed sort of a profile and a leadership sort of situation where we felt like we were ready to jump to the next step, and do a proper RCT. So I ran 2 trials. One was Swift Prime, which was these are all the PIs. The second thing was a Calgary-centered trial, which was a sort of a purely academic trial, which we designed and ran from Calgary. One issue that we hadn't solved was what we call cherry picking, in which essentially if a 57-year-old comes with an acute stroke, you treat the patient outside of the trial. If an 89-year-old comes in, you treat it inside of the trial. So this was an issue which we thought was the biggest single problem. I wrote this editorial in Neuroradiology. We call this the elephant in the room, that this is the biggest single issue that was left. And we used all kinds of ways to sort of get past it in terms of how do we get past it, limited number of centers, IMS-III results helped. We talked about sort of what is equipoise. I wrote multiple different editorials on various issues. And this particular one, endovascular stroke trials, why we must enroll all patients. Just to write this editorial, I probably read like 4 or 5 textbooks on various things. And if you are not familiar with this, I would recommend that you read it. It'll probably help you in your career in terms of the importance of trials. Just one second, guys. Sorry about that. So this is something that you may consider reading if you're interested. So then we started talking to people, and we also wrote about consent, the importance of sort of why consent is important, how to do it, those kind of things. So essentially, we sort of built up towards overcoming the problems of IMS-III. The other thing that we realized was that now trial design was quite easy. I wrote this editorial, is execution more important than design? This was published in Stroke. And then I did this mathematical modeling in terms of the problems of IMS-III and how we were going to solve them, whether it was related to workflow, the quality of recanalization, enrollment of the correct patients, dichotomous analysis, shifting it to shift analysis. And we made all kinds of calculations in terms of how effect size would play out. And the only problem that we hadn't solved was this idea of cherry picking. So from that perspective, we wanted to sort of move on to the real world and convince people that enroll the right patients and let's get it going. We started training people in terms of how to open vessels fast. This is again published in Stroke. So this is sort of an overall algorithm of what I just told you in terms of how we work in Calgary and the number of minutes saved at each step and how we sort of learned it over sort of the last 7 to 10 years. And we put it all together and published it so that people could use it. And then we sort of narrowed it down to what are the 4 biggest things. Keep the imaging simple, don't do any complex stuff, parallel workflow and teamwork, and then pre-organization of angio, brisk recanalization, ischemic stroke kit, what we call it. So this is finally how we ran the trial, and this is sort of the main paper of ESCAPE that was published in February, and the main results, which I'm sure you're aware of, that 53% good outcome in the treatment arm, 29% in the control arm. And if you look at the common odds ratio for a shift analysis, a pretty dramatic common odds ratio. This is another way to look at the same data. So essentially, MRS 0.2, there's a dramatic impact. Mortalities, there's a dramatic impact. And this is a way that our media department made it, and we use it now to take consent. If you don't get the treatment, so in the medical treatment arm, 3 people have a good outcome, 5 have a bad outcome, 2 are dead. If you're in the treatment arm, 1 is dead, and 5 have a good outcome. And this is extremely important for another reason as well. The other reason is for patients' families to understand that the treatment is not perfect. We still have a long way to go, that in spite of treatment, a significant number of patients will not do well. And this is an important concept to understand, and also takes us to the denominator fallacy, and also takes us this issue of transporting the correct patient to the correct hospital. But essentially, we still have a long way to go to solve the problem of acute stroke. Now, some patients in ESCAPE got IVTPA. They still had benefit. Patients who did not get TPA, they still had benefit. It didn't matter whether they got TPA or not. And this is the Kaplan-Meier curve for mortality. And this is sort of the sub-analysis, and this is sort of a pretty proud of this analysis. Every subgroup showed benefit. In fact, when we had the closeout meeting for Escape, one of the things that we did was we printed this on T-shirts and gave it to everyone. So all of us were roaming around in Banff, which is sort of close to Calgary, wearing these T-shirts up in the mountains. But this was printed on the backside sort of thing. So just a little nerdy thing we did at the end. And then we started doing all kinds of sub-analysis. So this were for collateral scoring and how does that play out. And essentially what we showed was if the collaterals are good, there is benefit. If the collaterals are moderate, there is still benefit. If the collaterals are poor, there is no benefit at all. So poor collaterals is the brain cells are dying so fast or already dead that even if you open the vessel really fast, you won't be able to sort of modify the outcome. Then we came up with this thing in education in terms of that you can use the collaterals to modify your reading of the non-contrast CT scan. So, and this is what our fellows do now. They look at the collaterals. If the collaterals are bad, they go back, they look at the non-contrast CT and modify their reading of the aspects. And obviously, if there's all kinds of other issues in aspects, motion, microangiopathic disease, old infarcts, then it could be sort of additionally beneficial. This is the other trial that I ran, which was the SWIFT prime. This was again published in NEJM, and essentially similar sort of inclusion criteria. I won't go into that. Once again, the phenomenal rate of opening the vessels using solitaire, and this is the main result. So once again, a dramatic benefit of endovascular treatment over IV TPA. And just to put it into numbers, 60% good outcome in treatment arm, 35% good outcome in control arm. And when we were pushing for all this speed, people told us you'll end up making complications, but with good training and knowing when to speed up and when to slow down, we sort of showed that there is no increase in the complication rate as a consequence of the procedure. And once again, the number of patients in SWIFT prime was less. So, but overall, everything in this subgroup analysis is to the good side of life. But one thing I forgot to mention earlier was the way that it all played out. There were 5-6 trials running across the world. Mr. Clean was the first one to reach the finish line. Their analysis came out in October of last year. And the day that their trial results came out, Michael Hill and we met up for breakfast early morning, and we said, okay, well, the trial results have come out. We were at 316 patients enrolled. And we said it's no longer ethical for us to continue the trial. And bang, right there, we decided we need to call an emergency. It was a Saturday. We needed to call an emergency meeting of our steering committee. 2 hours later, we had the steering committee meeting called, and we sort of stopped the trial, put the trial on hold till further decisions were taken. And what happened was it created a sort of a domino effect, and within the next 1 week, all trials came to a standstill. And the way that it played out was that the effect size was so massive that even though all trials came to a standstill, all of them ended up becoming positive. The other opportunity that we had is we had a detailed analysis of workflow and efficiency within the endovascular arm. The way that it played out in SWIFT prime, approximately 1/3 patients were drip and ship, which means they first went to the wrong hospital and then to the right hospital, and around 2/3 were coming to the mothership. And it was an interesting analysis because we kept track of all kinds of times. In SWIFT prime, I was in charge of quality assurance for the study. And this was sort of the main metric that we were measuring, qualifying image to groin puncture under 70 minutes. And I had created this form where as soon as a patient was randomized, they would fill in all these forms, send it to me. I would look at it. I would calculate the times. I would review it. I would give them feedback. If it was good, I would say, okay, what can we learn from you? If it was bad, then we'd say, okay, what can we sort of teach you? So typical kind of form that would come to me. Then I would send an email out saying, let me take a moment to congratulate you and how can we learn from you? And then we created a newsletter to get a competitive spirit going and sort of telling who's the fastest and who's the... Anyway, I won't go too much into results, but this is one thing I want to point out to you, since most of you are in US, as far as I can understand, that this is the mothership and this is drip and ship. And there's a delay of, on average, 2 hours that gets produced as a consequence of going to the wrong hospital. And this is massive. This is massive. So if you think about 2 million neurons per minute, 250 million neurons are dead just because you ended up going to the wrong hospital. And this is, in my opinion, the single biggest struggle that we have right now in the short term that we need to solve. Once you get to the correct hospital, things are now getting slowly well-oiled in terms of getting the imaging decisions, opening the vessel. That all is getting better and better. But this part is where we all need to work together and solve it. I'm going to, there's some other things. For example, let us say if you did CT perfusion, that slowed down things, but that is sort of expected. But the results were, that was not a massive delay. The other thing is, as interventionists, we are slower getting into the left side compared to the right side. That requires additional training, additional ways to think about how to get into the left carotid as opposed to the right carotid. We did a similar analysis for escape as well. In escape, we had even more aggressive targets. We did CT head to groin puncture in 60 minutes and CT head to first recanalization in 90 minutes. Just to remind you, in Swift Prime, it was qualifying image to groin puncture in 70 minutes. So firstly, the time was longer. Secondly, the starting point was different. So escape was by far the fastest trial of all the recent trials. And then we had a quality improvement program similar to Swift Prime, giving people feedback, learning from them, teaching each other. But this is something that I'm really proud about because I've spent 10 years of my life doing this. So the median time in escape was CT to groin puncture of 51 minutes, CT to reperfusion of 84 minutes. Mind you, in escape, we didn't use perfusion imaging, so that saved us quite a bit of time. And these were much tougher patients compared to some of the other studies where many of them had T or L occlusion, and many of them had carotid occlusion in the neck. And around 3/4 of the patients were treated with TPA. And escape was the only trial of all the recent trials that showed that a mortality benefit, a statistically significant mortality benefit. And once again, people were telling us, you're pushing too hard for speed, you'll end up with increased complications. There was no increase in the number of complications as a consequence of pushing for speed. So the main message here in terms of sort of looking at these time intervals is that now we've reached to a stage where the time is pretty evenly spread across all the things that we do. And as we have to get better, or as we have to implement the escape results as different sites, one of the things to think is there is no distinct bottleneck left. Ultimately, you have to save 2 minutes here, 3 minutes there, 3 minutes by not putting a Foley's, 2 minutes by not doing a groin shave. All that kind of stuff has to happen if you have to achieve this or make it even better. One of the things we still have to work on is daytime hours versus after hours. The patients are slower after hours just because the team is not in-house. The other thing we found was high enrolling sites were faster than low enrolling sites. And this is another thing that we have to think about going into the future as to how do we create systems of care that, you don't end up with 35 centers in Chicago, but instead you have 5 centers who are very good at what they do, covering the whole of the Chicago city sort of thing. So essentially, it's now standard of care. There's no sort of doubt about it. 5 positive trials. You have to think in terms of workflow and teamwork. You have to think in terms of a Bayesian way of decision making and a quick, fast imaging to make a decision. And this is the new guidelines from American Stroke Association. So this is the main sentence here: Class 1, Level 1A. So the last sort of 5 to 10 years of my life have been spent for this one paragraph to come into print. And these are now standard guidelines. They're there in Canada, they're there in Japan, they're there in China, they're there in Europe. These are the Canadian guidelines, which say the same thing. So where do we go from here? We now have the proof and evidence. And if you think about proof and evidence, there's 2 kinds of proof. One is this kind of proof, the Pythagoras theorem, where it is true whether humans exist or not. It was a true 1,000,000 years ago, it will be true 1,000,000 years from now. Or for that matter, Euclid, and the father of geometry, who started with some postulates and came up with the whole field of geometry. But this is the world that we live in, the world of randomness, where it's not so precise. In fact, sometimes we don't recognize randomness very well. If you get a chance, read this book, Fooled by Randomness by Taleb. It's really sort of worth reading to understand how humans are not good at understanding randomness. So really, the world that we live in is more like sort of, this is seen from Few Good Men, that where we live in is sort of what is the judicial definition of beyond reasonable doubt. And essentially now with 5 positive trials, which have very similar results to each other, we are beyond reasonable doubt that endovascular treatment is better than no endovascular treatment in these patients. These are the 5 trials. The result is so robust that you can take out 1 trial out of there, 4 left, and the result is still the same. And essentially, as you can imagine, the bigger trials where the numbers are higher are more stable. So if you take one of the smaller trials and you just remove 2 patients from there, it starts to cross the unity line. So importance of numbers, importance of multiplicity of trials. And if you take patients that did not use CT perfusion, trials that did use CT perfusion, the result remains the same. So it doesn't matter whether you use CT perfusion. It's a very, very robust result. And finally, I'm going to end with this. The brain is not the heart. So, one of my friends used to say, never have respect for an organ that can be transplanted. There is no such thing as a brain transplant. The brain is unique. You need to know your brain anatomy. You need to know how to get past it. It's not like treating the kidney or the heart where one cell is the same as the other cell kind of thing. So essentially, the only thing that we can do is save neurons. We can never sort of transplant it, and that is what we have to work towards. And this is what we need to do: 5 T's to time: transportation, teamwork, training, technology, and technique. These are the 5 T's, as I call them. I'm starting a conference which is called the 5T Conference. The first one is in February 2016. If you get a chance, come visit us up here, up in Banff. Some beautiful skiing out there. So this is the Calgary Stroke Program, first stroke course, keeping these 5 T's in mind. We also have to think about how do we sort of do the training. Angio experience is dropping due to dropping volumes. How do we train people to do this well? We have to think about who should do this, and the brain is unique. It's not sort of, okay, I've been doing heart angiograms for 10 years, so let me just go start doing brain angiograms kind of thing. And then, as I said, the biggest problem is building teams and getting the correct patient to the correct hospital. And then there's also controversies around imaging, but the key things to think about is time is brain. You have to think of a decision-making paradigm and use Bayes' theorem. Is it time for the rebirth of neuroprotection? I think it is. We finally have a, so to speak, a temporary MCA occlusion human model where we can consistently open the vessels. So this is where I'm going to be focusing the next 5 years of my life, is that now is their time for rebirth of neuroprotection. Along the way, I wrote a lot of articles, a lot of editorials, a lot of various things that I wrote along the way convincing people. But there's one that I wrote which is called Challenges of Acute Endovascular Trials. And I wrote it before these trials were over. But looking at it backwards, the single biggest challenging was actually randomizing the patient when in your heart you sort of felt like that you can do benefit for this person. And I'd just like to thank all the centers and all the families and all the patients who sort of participated in the trial to make it a super, super success. We had 5 positive trials in 1 year, all in NEJM. Everyone had a very good number needed to treat. These are the 5 successful trials. So essentially what it comes down to is there were a few good ideas along the way, looking at collaterals, better devices, a lot of teamwork, a lot of tenacity. But ultimately, you know, there's this book by Malcolm Gladwell where he talks about the 10,000 hour rule. Essentially, bottom line is it was a lot of hard work by a lot of people to make it successful. So I'm going to stop here. Thank you very much, and it'll open it up for questions.
All right, thank you so much, Dr. Goyal. It was an excellent talk about really an incredible treatment and a revolution over the past year. So I want to encourage anybody in the audience, please, enter your questions into the question box or into the chat box, whichever is easier for you. There were a couple of things. Being from the United States, where getting to the right hospital is really a big problem, I was wondering specifically in that setting, first of all, is there any medical center, any system that's actually working within the U.S. system that's doing this well, mimicking the Calgary system? And also, is there a lesson to be learned from interventional cardiology, because they've kind of gone through this exact situation with those hospitals that had cath labs, gave all time to balloon. They've already kind of gone through this process in developing and getting through the bureaucracy. So is there a lesson to be learned from them?
Like, are you asking me the question, or are you asking it to the crowd?
No, I'm asking you, yes.
Well, like in the sense, I can't tell you an exact answer to that question. One thing you have to remember is, at least at the current moment, the volume of heart attack patients is much, much higher than the volume of stroke patients. So the heart lessons only go for up to a point, because what happens is that, let us say there are total 100,000 strokes in a year in North America, and let us say there are 700,000 heart attacks. Then what happens is that the whole formula for success ends up becoming different just because of the magnitude of disease and number of patients and all that kind of stuff. That is one part. The second part is the heart attack has pain, so it's much easier to sort of train people to realize that this is a heart attack, and they can sort of end up showing at the hospital themselves, which is different for stroke. The third part is that what I find as I travel around is that different areas end up having different solutions. You have to work with your paramedics, you have to work with local champions, you have to work with local political leaders and stuff. So I don't have a uniform solution or uniform answer to your question. I do recognize it's a problem, and I do recognize the solutions will have to be local, as opposed to sort of a central solution, which one solution for every situation. I don't think that's going to work.
Okay, and actually along those lines, we have a question from the audience about whether there should be a certain volume of stroke interventions that a certain center should have per year.
Yeah, so I'm not in the business. I'm not in the business of policy making as to what that volume should be, but yeah, on an intuitive level, it makes sense. Like there's enough data in the field of medicine that, you know, if someone is doing kidney transplants, if someone is doing pediatric heart surgery, if someone is doing liver transplants, ultimately you need to reach to a critical volume to sustain the team, to make everyone familiar with it, to run a well-oiled machinery. It's common sense.
Mm-hmm. And with regard to additional imaging, I know you'd mentioned in terms of the time, do you think there will ever be a role for something like MR perfusion or any of those modalities, considering that they might be more accurate than CT perfusion, even to include a patient that might have otherwise been excluded? Or do you think that's never, no matter how fast it gets, that there will never really be a role for that?
Here's the way I think about it. Here's the way I think about it. So 2 million neurons a minute. What I'm willing to spend on imaging and decision making is 10 million neurons. And technology will evolve. If it reaches to a stage which is better than the current CT angio paradigm, in which you can get it in 10 million neurons, 5 minutes, the decision, and move on, I really have no attachment to any one form of imaging and one form of this thing. So whatever makes it work and whatever is the best to move forward. But the question is, it's a balance between time spent and the information and decision that you get. At the current moment, it takes more than 5 minutes just to exclude the patients with pacemakers so that they are eligible for MR. So it's not just related to the time it takes to do the MR. It's the overall process time where you have to ask the family, okay, does this person have a pacemaker, or examine their chest, or look at a chest X-ray, or look at their records to figure out whether they have a pacemaker or not. By that time, the CT angio is sort of already done. So, but at the same time, I've visited centers that have been using MR for 10 years. They are very slick at it, probably not as slick as the CT guys, but they are slick in many CT centers. So, and they're very used to doing it. So I don't want to sort of focus on this issue of CT versus MR as much as focus on this issue of the time and a Bayesian decision making. Things will evolve, things will get better, and people are will figure out what makes them most comfortable.
Okay. We have a couple questions actually about posterior circulation interventions as well, in terms of how you do them. Is the timing different? How do you approach that at your center?
So a couple of different things. Firstly, the posterior circulation stroke, it was never added into level 1 evidence. So it's going to be sort of, so to speak, case series, case studies, level 4, level 3, expert opinion, all that kind of stuff. So take whatever I'm saying with a little bit of pinch of salt. That's one part. The second part of it is in terms of posterior circulation, basilar occlusion. There is sufficient data to say that the natural history of disease is super, super bad, where if you don't open the basilar artery, it's unlikely to have a good outcome. So which means that from the point of view of having benefit, if you can open it and a certain number of patients improve, you still are doing significantly better than not treating any of them, kind of thing. The third part of it is there's obviously sort of the disease that affects posterior circulation very often is different. So basilar occlusion very often can be due to intrinsic disease in the basilar artery, in atherosclerotic disease, especially if it's in the proximal part of the basilar artery, which doesn't happen that often in the North American population for anterior circulation stroke. It does happen in Asia, but not so. So the disease to begin with is also different, especially if it's a proximal basilar occlusion. So the treatment of sort of posterior circulation stroke, the way to think about it, how to use the devices, how to get past sort of obstructions, it's almost like a talk in itself. So I won't go into too many details here. Just to let you know, natural history of diseases, basilar occlusion is very rare, very bad. The disease in itself is different. Very often it's atherosclerotic disease, and there isn't very good RCT data as to what you should do with them. Hello?
Hey, I'm actually not sure if Dan's still here or not.
Oh, I'm sorry. I was muted. I didn't realize it.
Oh.
Sorry, I was reading the question while I was muted. So another question from the audience, Dr. Goyal, with TPA plus intervention versus interventional alone without TPA in terms of your post-procedural intracranial hemorrhage?
So in the data that is available, giving TPA did not increase intracranial hemorrhage. That's one part. The second part is the current American Stroke Association guidelines clearly states that if TPA is indicated, it should be given. The third part is there are at least 2 trials that I'm aware of that are being planned to answer that question.
Okay, great. All right, so I believe that's all the questions we have so far. I'll give people just another few seconds. All right, so I guess we'll end it there. Thank you so much, Dr. Goyal. We really appreciate you giving the talk, and thanks everyone for coming out tonight.
Okay, thank you. Okay, bye-bye.
Good night.